Good afternoon, everyone, and welcome to our faculty office hours. As you know, we try to record these sessions, so we just are trying to decrease the amount of background noise. So I'm really excited to be moderating this session this afternoon with the theme of urinary tract infections by Dr. Surbi Lika, who did the program 2 weeks ago. And it was a very well attended and very successful program. For those of you who weren't able to be at the program, let me just share a little bit about Dr. Lika's background. She's an infectious disease physician and associate professor in the Department of Epidemiology and Public Health at the University of Maryland School of Medicine. She's completed her medical training abroad in India, and she did her master's in public health from the University of Massachusetts. She's completed her internal medicine residency and infectious disease training at Mayo Clinic in Rochester. And she currently serves as a medical director for infection prevention and hospital epidemiology at the University of Maryland Medical Center. She conducts research on healthcare-associated infections with a focus on surveillance, methodology, implementation science, and infectious disease diagnostic stewardship. And as I mentioned, her webinar was one of the best attended and an outstanding in terms of feedback. And we're really fortunate to have her as part of our team here at the University of Maryland School of Pharmacy Peter Lamy Center and the Maryland Department of Health. So, Dr. Lika, we did get some additional questions, some that were added, and I believe we also have Dr. Heil and Dr. Clays on the call as well. If there's any other faculty that are present, if you could just chat in to the chat box and let us know. In case you are muted, we will unmute you just to make sure we include everyone. So I'm going to jump right in to the faculty office hour questions and go from there. So one of the first questions that was shared is, could you please send us some handouts for our in-house staff education? I do want to just give a quick shout out here. We do have a website. They're in our slide deck that we'll post. But we do have a website where we do have some references to the work that we've done through this program, as well as some of the work that's being done on a state, regional, and national level. So with that being noted, there are some handouts that already exist. But I just wanted to ask any of the other faculty if they have any additional comment to that question. And again, if you are in a large group or have background noise, could you please mute yourself? Okay. All right. So Dr. Lika, this one is definitely a great one in terms of diagnostic stewardship and the importance of understanding some of the concerns that are out there by practitioners and systems. From your clinical experience and your read of the literature, is there an increased correlation of untreated urinary tract infections and sepsis?
Okay, I think I'm unmuted. Can you hear me now?
We can hear you now. Perfect. Thank you.
All right. So that's a great question. And I think probably one of the reasons why we fear UTI and want to diagnose and treat it very quickly. So, you know, the challenge is really, what are we calling untreated UTI? What I can share with you that you know, there is a lot of evidence that for patients who have asymptomatic bacteriuria, and these are primarily studies that are done in the outpatient setting among women, that if you treat women that are asymptomatic but have but carry bacteria in the urine, so they have a positive urine culture, if you treat them, then that does not prevent subsequent symptomatic UTI. So that's, I think, a very important point as we think about, you know, how we are selecting patients for treatment. And the second related point is that when they do get subsequent UTIs because of prior treatment, they're more likely to have infections with more resistant bacteria. Also, in healthier individuals, you can wait, and even if they have symptomatic UTI with primarily lower urinary tract symptoms, those can often resolve on their own. Now, that is, of course, not the population that you have in long-term care, but I think the challenge is really, as we discussed on the webinar a couple of weeks ago, distinguishing between true UTI versus a positive urine culture in someone who some just non-specific symptoms and would really be asymptomatic bacteriuria. So in a patient who is a long-term care facility resident, if you have a positive urine culture in the setting of appropriate symptoms of UTI, then the recommendation would be to treat. But if there's any question that the positive urine culture represents asymptomatic colonization or bacteriuria, then the recommendation would be to wait and watch.
Thank you. And I think that actually gets at the third question a little bit as well. What is your opinion about a urinalysis with culture reflex test, which with a urine white blood cell count greater than 10, yet no other parameters of the urinalysis? Is pyuria alone sufficient enough indication of, as you put, a true urinary tract infection?
Yeah, so, the urine reflex culturing is probably one of the more misunderstood tests in UTI diagnosis. So the reason to do this reflexing of based on a urine white cell or some other parameters is not to say that what's going to give us a positive yield and tell us that the patient has UTI. It's really to tell us who might not have a UTI. So what do I mean by that? The reason to predicate doing a urine culture on white cells in the presence of non-specific symptoms is just to select out those that may not need a urine culture at all. So, and the rationale for that is that absence of urine white cells is a very strong negative predictor for UTI, has a great negative predictive value. So if I don't have pus cells in my urine, that makes it highly unlikely that I would have UTI. So we only want to do cultures in those that may have a positive white blood cell. However, on the other hand, just because you have white cells in your urine does not mean that you would have a UTI. So you don't want to do a reflex culture. Again, it comes down to when people are asymptomatic or symptomatic. You don't just want to go do a screening UA and then look at what their urinalysis looks like and then decide to culture. The culture should only be done on the basis of symptoms, because what the culture is telling you is really which bacteria need treatment. The culture is not making your diagnosis for you. So you could select a white blood cell. You could also select other parameters. Some of the other parameters that people commonly use are nitrite and leukocyte esterase. But leukocyte esterase is very similar in which it's telling you about the presence of white cells, but it's doing that without doing microscopy. Similarly, a nitrite tells you about the presence of bacteria because a certain bacteria reduce nitrate to nitrite, but it does not tell you whether the patient truly has an infection. So all these tests are telling you about presence of bacteria or white cells, but not about a UTI, which again comes down to the patient's symptoms. So I'm not sure if that explained or answered that question, but pyuria alone is not sufficient an indication for UTI. The reason for reflexing is to use it for this negative value and decide who does not actually need a urine culture.
Well, that was a very comprehensive answer to a complicated question. So I think some themes I'm hearing, and Dr. Lika, correct me if I'm wrong, is we really need to define the symptomatologies that these tests will either be helpful to eliminate needing to do further testing or maybe confirming a true UTI when you place it in collection with the patient's symptoms. Is that a good way to say that?
Yeah, that's exactly right.
Great. So I think just to get at what you hinted at, but getting again at understanding the test and how the urine collection is done and the specimen. So this fourth question, and we just got another with the chat box, but we'll go to this fourth question first, is are you aware of any evidence behind the theory that the nitrite test loses sensitivity the longer the delay in testing following collection of a specimen for urinalysis? And I'll give a little bit of a background experience. So in long-term care, there may be a delay before that specimen is picked up and taken to the lab. So, which is unlike a hospital system where things are taken to the lab quickly. So a little bit about the specimen collection and then the concern regarding the test.
So that's a good question. I will admit that I don't actually know the answer about whether a delay and what amount of delay would lead to losing sensitivity for the nitrite test. But I would go back to saying that it actually is not a very sensitive test. When you find nitrite, it is specific for the presence of bacteria, but the overall sensitivity is in the 40 to 50% range for UTI, and that's partly because this test is based on the ability of bacteria to reduce nitrate to nitrite, and not all bacteria are capable of doing that. Particularly the gram-positive bacteria are known to not have that ability, and there are also different factors that may affect the ability to detect. And the one that I'm familiar with the most is that pH in particular. So when you have a low pH, that can lead to false negatives for nitrite, and that has also been the basis of the use of vitamin C, which or acidification of the urine as a means to prevent UTI, because that inhibits the ability of bacteria to do this conversion.
So Dr. Lika, that's another great answer. So you just hit at something that I didn't even think about. But so if patients, for whatever reason, do have changes in their pH of their urine, that could also, maybe if they're on some of these supplements, could affect the test results too?
Probably, yes. I think that would be true. If you've lowered their pH enough, then you probably won't be able to get a positive nitrite test.
Okay, interesting. Okay, well, there are some limitations in the test. I just have to ask personally, how do you keep on top of all of this? Diagnostic stewardship, it just seems, and understanding the test, sometimes we, I think, take for surface value what these tests mean. So are there good resources that can help guide us to understand the test a little bit more?
So the one resource that I like quite a bit is the lab Cumatech guide, which is available, and we have it from our laboratory colleagues, but it's called the Lab Diagnosis of Urinary Tract Infections, and it's published by the ASM. I think I had that reference in my webinar, but I can certainly send that to you, and that talks a lot about the different tests that are used in the diagnosis of UTI, the sensitivity, specificity, and some of the limitations. What it does not always touch upon is, again, the clinical context in which tests are used. So if you're starting out with an asymptomatic patient, then you may detect bacteriuria, but that might not be the goal, right? Because the answer you're looking for is whether or not this is a UTI. And again, making that same point that the test is not always going to be the answer to that.
Great, very helpful. Thank you. Yeah, if you wouldn't mind sharing that, we'll make sure to share that with the faculty office hours for suggested readings for the future. Now, this question just came over through the chat box, and I encourage others, if you have additional questions, this is an amazing opportunity with an outstanding faculty member to address some of your clinical concerns, as I'm asking my own here too. So thank you. The other question we have is, what is your expert opinion regarding antimicrobial prophylaxis for patients with frequent urinary tract infections? Is there sufficient evidence to support a benefit for certain patients?
Right, so this is also another very good question and comes up not infrequently. So I think the two things that need to happen before, well, at least the two things that need to happen, there might be more, before a consideration is given to what we would call suppression or prophylaxis for someone with frequent UTIs is A, what is it that is predisposing them to frequent UTIs, and is there an underlying cause that can be corrected? And the things that are commonly seen and are correctable would be things like stones in the bladder or in the kidney. In men, often prostatitis or prostate abscess or even prostate hypertrophy, which causes poor drainage of the bladder, can lead to recurrent or frequent UTIs. I think in your population, in long-term care facility residents, often in elderly women, there may be nothing more than just, as the bladder ages, the ability to empty the bladder just gets poorer with time, even in the absence of an overt neurogenic or static bladder. But it does require us to make an effort to make sure that there is an underlying cause, that there is no underlying cause that can be corrected before we just say the patient is doomed to have recurrent UTI. The second and important aspect is, again, one that we've been talking about with UTI diagnosis, is really making sure that those are true recurrent UTIs as opposed to just someone who has a persistently positive or recurrently positive urine culture, because that actually is the more frequent scenario, particularly in elderly women who may have a very high rate of carriage of bacteria in the urine. As many as 50% of long-term care facility residents who are elderly women may be just colonized. So before you label them with frequent UTI, make sure that you've associated that with true symptoms, and then for consideration of prophylaxis. Now, there are guidelines and criteria of, when you consider suppression. I would encourage people to actually look at the IDSA guidelines. And I think that's something we can also post, but, to have certain number of episodes that are symptomatic before you consider placing them on a suppressive or prophylaxis course of antibiotics.
Wonderful. Great. Again, really good good information, and can't hit it enough. We have, just sharing a story for a second, a woman with reoccurring urinary tract infections, and to your point, understanding the underlying cause because of, it's more of a bladder prolapse and some anatomical changes that had happened. So, it's really, really important to think about that, let alone the hygiene aspect. We have many patients that are incontinent of urine that may not be getting adequate, good hygiene in terms of changing of the undergarments or things like that. So really, I think you hit on a really important chord, because too often than not, we just try to treat the symptom without really understanding where it's coming from. So that's the principles with stewardship. So thanks, Dr. Lika. We do have another question, so thank you for using the chat box today. So as you can see, this is a really important topic. So the next question we have is, what is your response to a provider who would still like to treat asymptomatic bacteria for a patient who happens to have had a urine culture which was positive, especially if they are concerned about an elderly patient unable to articulate possible symptoms and with some level of mental status change? Boy, if that's not a question we get a lot, right?
Right. So I'll try to break this down into two, perhaps. I think the first part of this is just, treating asymptomatic bacteria, which is what we started out with, for the response to the question of whether not treating leads to harm, and the answer is no. So if it's truly asymptomatic, and you're not treating them, that is not harmful to the patient. I think the one thing I do want to add, thinking back to that first question we started with, is that there are some scenarios, and there are very few, in which treatment of asymptomatic bacteria is recommended, and I don't really think that applies in your setting. So one is pregnancy, and the other is preceding urologic procedures. In both those cases, not treating asymptomatic bacteriuria has been associated with harm. So in the case of pregnancy, it can progress to upper tract infection. And in the case of patients undergoing urologic procedure, you can disseminate bacteria from the colonized urinary tract and lead to bacteremia or bloodstream infection with the urinary organism. So those are two indications for treating asymptomatic bacteriuria, but other than that, there really is not evidence to say that an asymptomatic patient should be treated. I think the second part is, so now you're getting to, well, are they truly asymptomatic, or do these mental status changes represent symptoms of UTI? And I spent quite a bit of time on this during the webinar. And I think showed some ways to address mental status changes, and also shared with you guidelines of the Choosing Wisely from AMDA, as well as the recently published and updated asymptomatic bacteriuria guidelines from the IDSA. And they both really say, one is that don't treat just mental status changes alone. So you must have at least something else that is suggestive of infection. So that's one approach to mental status change. The second is really different ways of, how do you assess the patient with mental status changes, with this idea that we often think that a patient really cannot articulate their symptoms, whereas if we did a really careful and, spend some time, which is hard, I know, but a time-consuming and thorough history and exam in someone who's really experiencing acute UTI symptoms, they should be able to articulate some of those aspects. I don't have the slides, but if you actually go to the webinar, I did go through some of the ways you can try to elicit those symptoms. So, repeating the same questions, asking the questions in different ways, accompanying that with an exam, asking very specific questions and wording them in different ways. So not just saying, do you have burning with your urination, but saying, does it hurt to pee? How can you phrase things differently to elicit some of those? And then lastly, on this idea that if you went down the path of attributing mental status changes to UTI, you might in fact be missing the true diagnosis for a given patient. And really that's an important thing to communicate with both staff and physicians, and also to the family that sometimes might be pushing for an evaluation for UTI for mental status change. So I would encourage you to go back to the webinar if you did not. I think this question should be answered based on that.
Great. Really, really, really important points. And I think the cues in terms of really getting a good symptom analysis are really key because of the critique regarding what does mental status change and who is that mental status change perceived by, right? So great points, Dr. Lika. And I had to chuckle because we had this question just the other day in our clinical setting. So I think we hear this a lot. So I'm going to ask the next question because we just got another question through the chat box. And again, encourage you to chat in your questions here. So, but feel free if there's any other faculty who want to chime in. But I'm going to go on to the next question. If we are tracking urinary tract infections on a log, and the patient had the infection twice in the same month, maybe a week or 2 week break after antibiotic treatment completion, will you classify it as one urinary tract infection occurrence within the same month or 2 occurrences on your log? So this gets at some of the discussions we've had regarding tracking and some of the quality initiatives and reporting aspect. So Dr. Lika, do you want to take a stab at that one, or any of the other faculty?
I can try. I don't know that there's a right or wrong answer here. It really depends on, what you're trying to get at. From the patient's perspective, if these are truly two symptomatic episodes of UTI, particularly with different organisms or even with the same organism, that's an important thing to figure out why they are having this quick recurrence or occurrence, what might be predisposing them. But if you wanted to do just, number of patients and patient level tracking, then, you could count it as one. I know from a surveillance perspective in the hospital setting, many of our rules just have a duration. So, we think that a week should be an adequate time, right, for someone to resolve their symptoms. And for many infections, we'll say if something is occurring after 2 weeks of the first one, then that counts as a second episode. So you might just want to make a rule that helps you from a surveillance perspective to make sure that you're doing it in a standardized way from month to month. That may not have the same clinical correlation. So again, I think it depends on the goals of counting something as 1 or 2.
Great point. I don't know if, I know Dr. Clays, you did some discussion earlier on in our webinars. If you're with us, if you wanted to add any additional comment to that.
Can you hear me?
We can hear you.
Oh, okay, good. No, I don't have much additional comment. I think it's a very gray area and very, very much dependent on the patient at hand. So it's really hard to kind of answer that question in a broad, overarching answer. So I think Dr. Leka did a really good job trying to address it from that standpoint. So I don't really have a lot to add from that perspective. I know it can be tough when you're trying to document these things, but as long as you're consistent in the way you document them, I think that's the most important thing.
Great. Fantastic, Dr. Clays. All right. I am not seeing any other questions in our chat box, so we'll give individuals a moment. Dr. Leka, any other thoughts as you reflected upon the webinar and some of the questions today of themes or things you think our attendees could take home, or any other points you'd like to make?
No, I think I just want to acknowledge that it's a very difficult thing to do. There's a lot of this, folklore and, the strong attachment to UTI, particularly among elderly patients and those with, some cognitive impairment, that anytime that they have, delirium or some change in their mental status, that, UTI must be in the differential. And that's the thing that I think a lot of experts nationally and internationally are trying to change. So it's a difficult thing to do, but I think to the extent possible, if people can work on that and make sure that they can get agreement among staff, that you're doing the patient and the family a favor by really focusing on the true symptomatic UTI. That's where the work and the effort needs to be. So again, I'm biased, and I know many of us are, because we do believe strongly in the diagnostic stewardship aspect of antimicrobial stewardship. But, the one slide I had shared last time, and this is again from the acute care setting, but, when they worked on UTI and got this, nice reduction, they did realize that 80% of that reduction was due to a reduction in culturing and not on the treatment side. So it's harder to make an impact on treatment if you're not reducing the unnecessary or inappropriate culturing. And also in the long-term care from Dr. Nace and Dr. Cernich's, IOU study, they also found the same thing, that with their multi-center study, they saw a reduction in antibiotic starts, but not necessarily in duration of treatment, again suggesting that when you come at it in the back end with just tackling antibiotic stewardship after you have a culture, it leads to smaller gains than you might get by reducing the number of positive cultures up front, unnecessary positive cultures up front.
Really important point. So there's another chat in the chat box here while we were talking, and I just want to stress the importance of, as you mentioned, diagnostic stewardship and preventing downstream implications. But here's the next question for the team. From time to time, residents are placed on prophylactic antibiotics for urinary tract infections. What is the risk of prolonged antibiotic treatment beyond 1 year?
Mm-hmm.
Want to start with that one, or?
No, it's okay. I wanted to see if Emily or Kim might have something to say.
Mm-hmm.
You know, it depends again on, you know, what they're being treated for, and you always want to weigh the benefits and risks of these, you know, prolonged courses. You know, if there is a sense that the underlying issue may have resolved, I think most, or even if it hasn't, most would recommend trying to take people off if they've been recurrence-free and giving them another trial of an antibiotic-free time period to decrease the side effects of antibiotics. The particular adverse effects themselves depend on the antibiotic that's being used. So again, you know, nitrofurantoin is a common one, but you know, over a long period of use can actually cause pulmonary fibrosis. So that would be a risk associated with that particular antibiotic, especially over months or years of treatment. And then we also, you know, we always worry about harboring resistant bacteria, you know, especially if you have an undrained focus or anatomically distorted urinary tract, as well as C. difficile infection from long-term antibiotic therapy. But other faculty members might want to add to that.
Dr. Heil or Dr. Clays, anything you'd like to add to that answer or response?
I don't think there's a ton to add, because I think, again, like Dr. Leka covered it very comprehensively. There's no one answer. There's no one quantifiable risk. You can't say after a year your risk of X, Y, and Z increases by this. We don't have that strong information, but it totally depends on the antibiotic and the ADRs associated with that, as well as the risk of developing drug resistance, again, hard to quantitate, and then the risk of C. diff. So I think those are all risks that we are aware of, but it's hard to really quantitate after 1 year mark exactly what that risk would be. We just know that it is present, and the longer you're on these agents, especially when you don't need them, the higher the risk gets.
Great. All right. All right. Well, I think we have another question. Okay, another question coming through here, guys. What is your opinion about not using pip/tazo for ESBL pathogens in a UTI, even though the culture shows sensitivity? What does data say about the effect of the tazobactam has on the testing process?
So this one, I think Dr. Clays or Dr. Heil would be able to answer better than me.
Okay.
So
Sounds good. Dr. Clays, do you want to take a stab at that? I haven't heard Dr. Heil jump in yet, so I'm not sure if she had to jump off.
Yeah, I can kind of take a stab at that. That gets into a whole other area of clinical, because there's a whole trial that just came out called the Marino trial, which antibiotic stewards and ID physicians are probably constantly hearing about right now, that kind of helps address that question. And I'm sure that's where that question came from. In fact, so start off looking at your urine culture. Your cultures are usually tested at a certain amount of bacteria, very similar or even a little bit more quantity than you get in your urinary sources in terms of the number of colony-forming units. So theoretically, the amount of tazobactam that's present in that, or the beta-lactamase inhibitor that's present, should still work, as opposed to like higher inoculum infections, where even if the ESBL is present, the higher inoculum infections, we probably don't have enough tazobactam to counteract that. So theoretically, in the urine, it should still work. Right now, they're actively looking at the Marino trial, which showed that in ESBLs, carbapenems were the drug of choice compared to pip/tazo. They're going back in that data and actually looking at the MICs, and there's some criticism of that trial that really makes it hard to delineate whether or not using pip/tazo in an ESBL urinary tract infection should or should not be done. I think, and I don't want to speak for Dr. Heil, but I think for myself, looking at that data, and again, this is a whole, you could talk about this for half an hour. I think if it is confined to the lower lower urinary tract, in a patient that is not critically ill, I would still feel comfortable using it, but anything outside of that, I would not feel comfortable. If it's upper UTI, which has a higher inoculum, if the patient's critically ill, I wouldn't feel comfortable using it because there's no guarantee that the amount of beta-lactamase inhibitor present can counteract the amount of beta-lactamase enzyme in the culture, or that the immune system can help sweep that up. So again, very good question, but also we could literally, there's whole talks on that at meetings recently.
Well, I think Dr. Claes, thank you, because I believe that there's topics like this that are very timely as we're learning more that this group can discuss hopefully more in the future. So I appreciate that. And if you, for those who maybe are not familiar with that particular study, if you could send us a link, we could post that with the faculty office hours as well.
This is Sylvia. I just wanted to add to what Dr. Claes was saying. That I completely agree with that. And the Merino trial specifically was in patients who actually had bloodstream infection. So, if you are concerned for, UTI leading to bloodstream infection and, sepsis in really sick patient, and that's the patient you would avoid the piperacillin tazobactam for sure.
Okay. I understand that this webinar is recorded. Can we get a copy via email? What we'll do is we'll post what's that? On the website. Yeah, we'll post the recording to our website, actually, which takes us to the next slide. And so just so you guys know, we have a lot of information on our stewardship website. So I really highly recommend the place that you go to register for the program is also the place to go to get the recordings from these programs and the slides and the handouts and additional resources. So, so we will definitely have this posted, and you can go to the website and obtain that. I did want to let you know, I don't think there's any other questions coming in, but just to let you know that the spring 2019 semester is over for our webinars and faculty office hours. I don't know if Dr. Brooks was able to make it, but on behalf of our state partnership, we've been really excited to offer these programs. And just with some broad reflections, I just want to thank our faculty members. I know Dr. Claes, Dr. Heil, Dr. Lika are on the phone. We've had numerous faculty, Dr. Shake and others, and there's many, Dr. Brooks and the team at the state, Dr. Zarowitz, who's moderated many discussions. I just could go on, but we've had a great team effort in putting these webinars and faculty office hours together. Couldn't do it without Edner, who's sitting right next to me navigating the information and the website. So I do want to say that this has been a wonderful partnership. I'm not sure what the fall semester is going to look like, but the summer is going to be a bit of a break. We will continue to house information up on our website, and as opportunities come up, we will post them and encourage you all to check there for some additional resources. We have seen probably over this series of webinars and faculty office hours about a good 400 unique registered attendees have varied based on the registration, but we're going to be looking at that in more detail for the future. So, so just wanted to say again, go to our antimicrobial stewardship website to get this recording from today, past recordings and handouts from our other faculty office hours as well as webinars. And so I believe we're coming to a close in terms of our faculty office hours, but we'll leave this open for any comments from other faculty on the call or any chats from any of our attendees. Well, I'm not hearing anything. So again, I just want to thank you all very much. I think this has been a really dynamic faculty office hours. And again, you have our contact information here at the Lamy Center. We will post this recording as well as additional references that were made from the office hours today. So have a great afternoon, and we'll talk more later. Thank you.